Welcome back. I hope you've enjoyed the first session of the Leveraging Reverse Transcriptase in HIV, Past, Present and Future virtual symposium. During the second session, Chloe Orkin and Jean-Michel will give a clinical review on new reverse transcriptase inhibitors. And the toxicity of different drug classes and their clinical implications will be discussed by Laura Waters. And I will emphasize the optimal use of nucleoside reverse transcriptase translocation inhibitors, NRTTIs, and non-nuke regimens in routine clinical practice. The second part of this virtual symposium will also end with a Q&A. During the Q&A, we will discuss your submitted questions. You can submit your questions by opening the Q&A field on the right-hand side of your screen. Type your question and press send. Please be so kind to complete the survey after the virtual symposium. We'd like to thank MSD for providing sponsorship for this educational meeting. MSD have had no input into the content or speaker selection of this virtual symposium. Chloe Orkin will review the clinical data on doravirine, a non-nucleoside reverse transcriptase inhibitor. She will summarize key findings from recently conducted studies and discuss current guidelines on the use of this novel antiviral drug. Chloe Orkin is Professor of HIV Medicine at the Queen Mary University of London and a consultant physician at Barts Health NHS Trust in London. Chloe is immediate past chair of the British HIV Association, Vice President of the Medical Women's Federation, and a member of the Governing Council of the International AIDS Society. Her specialist interest is antiretroviral therapy. Thank you, Chloe.
Hi, it's wonderful to be here with you. And what I'm going to do is do a clinical review on the new and exciting reverse transcriptase inhibitor, doravirine. Here are my disclosures. So what I'll do today is I will cover doravirine plus NRTIs, and then I'll cover doravirine plus its new partner, islatravir. So I'll start with doravirine plus NRTIs, and I will cover the treatment naive efficacy and safety first. So in terms of doravirine, it's a novel next generation NRTI, and it has a unique resistance profile with in vitro activity against wild type HIV-1 and the most prevalent NRTI resistance mutations, which as you all know are the 103N, the 181C, 190A, and the 138K. And it's dosed once daily without any regard to food. And one of the unique selling points is that it has a low potential for drug-drug interactions, particularly with commonly prescribed drugs like acid-reducing agents, statins, and metformin. And very importantly, it's been approved both as a single tablet regimen together with TDF and 3TC, and also as a single entity as doravirine. And that means that it can actually have the versatility to be used with other backbones if necessary. So I'm going to talk through two large phase 3 double-blind RCTs for treatment-naive individuals, and there are 680 people that we are talking about here. The first study is the Drive Forward study versus darunavir, which the top line findings were that it was non-inferior with a superior lipid profile. The next comparator was against efavirenz, and this showed non-inferior efficacy with superior neuropsychiatric and lipid profiles. Now, it's important to note that it hasn't been compared against integrase inhibitors, and this is a drawback in terms of comparators. So in terms of baseline characteristics, what I would say is that this particular cohort recruited predominantly male subjects in terms of receiving doravirine, only 15% were women, and the patients were predominantly white and predominantly had viral loads less than 100,000 copies, almost 80% of patients. So these are important points to note in terms of baseline characteristics. So it's the summary of the clinical efficacy data. What I said earlier is that you can see that doravirine, which is always going to be shown in green, was non-inferior to darunavir at week 48 and non-inferior to the efavirenz containing regimen at week 48. And if we look at the efficacy data by subgroup, this is really, really important data, because what we see here is the stress test of a regimen when we look at the parameters for patients who had high viral loads and low CD4 counts. And what you see for the drive forward study against darunavir on the left, and the drive ahead study against efavirenz on the right, is that regardless of baseline viral load, the outcomes were very similar. And we see also that there was no crossing of zero in terms of the confidence intervals, even for the patients who had low CD4 counts. So this is really reassuring data in terms of the efficacy of this drug. What about resistance? So it is an NNRTI, and I think there were hopes at the beginning that this drug would be like an integrase inhibitor in terms of resistance, but unfortunately it isn't. So what you see is, in terms of those patients who had resistance, there were very small proportions of patients who actually were non-responders in the regimen. But in terms of NNRTI resistance, what you saw for the darunavir regimen was 7 patients with NNRTI resistance. And interestingly, if you compare it to efavirenz, there were 12. So it was about a 0.9% of the patients who had resistance for darunavir. Obviously, we would expect none for darunavir, and we had 3.3% for efavirenz. So you do see a difference in genetic barrier for the second generation drug. But importantly, those patients also had primary NRTI resistance. So what were the mutants? Well, the mutants were the A98G. They were also the 227, the 106, the 225, and those were the predominant mutations with the regimen. In terms of adverse events, it's very tolerable. We see for the drive forward study, only 14% of patients had diarrhea. This was the most common event. For the drive ahead study, we see very low rates of discontinuation, statistically fewer than with efavirenz, and we see fewer discontinuations. Importantly, the neuropsychiatric effects against efavirenz were far better, and I'll show you more about that on the next slide. So looking at the neuropsychiatric adverse events at week 48, you see that they were statistically better than efavirenz for dizziness, sleep disorders, and also altered sensorium. So this is a real benefit. In terms of lipids, once again, you see that for darunavir in green, there were favorable lipids against darunavir and against efavirenz, and you see that some of these parameters were in fact statistically significant, particularly when we're looking at the total cholesterol and the LDL cholesterol, non-LDL cholesterol. So at week 96, here we're going to look at the outcomes against darunavir. And what we see here is that in this study, by this time point, darunavir was superior. Now, this is something that has been shown in other week 96 studies, that at week 48 it shows non-inferiority, and by week 96 it's superiority. So why does this happen? This is something that happens when there is a real difference in the adverse event profile, and people get tired of adverse events in the second year. So we see this against darunavir, where ongoing diarrhea can be an issue. But in the study against efavirenz, it remained non-inferior. Now, this is probably because those patients who had significant efavirenz-related side effects, CNS side effects, wouldn't have put up with them beyond the first year and would have been switched. So the main differences were in the first year rather than the second year. So in summary, in the naive trials, darunavir was superior to darunavir, non-inferior to efavirenz at week 96. There was a 1% protocol-defined virological failure. The lipids remained favorable week 96 for both of the drugs, and the neuropsychiatric adverse events also remained favorable. Now, this is an interesting little study, the Drive Beyond study, and I bet you very few of you have heard about it. I know that I hadn't heard much about it. So this was a study that was meant to enroll 60 patients, but in the end, it only managed to randomize 10 patients, and these were patients with baseline resistance. So the aim of the study was to recruit people who had the common NNRTI resistance mutations that darunavir as a second generation NNRTI is supposed to be sensitive to. However, because they couldn't recruit, they had to discontinue the study early, and we were not going to know whether this actually worked. However, what we can say is that there were some discontinuations, 2 discontinuations out of the 2 patients that were enrolled, and actually there was actually resistance. So I'm going to move to switch studies. So the DRIVE-SHIFT study was the big switch study, and this was a large open label trial switching patients from a stable antiretroviral regimen to Doravirine 3TC and TDF. Patients had to be undetectable for 6 months, and they couldn't have had any known failure to the study drugs. They had to have a GFR greater than 50 because we're using TDF. They were 80% male and white, median age was 43, and importantly, 70% switched away from a PI, 30% from an NNRTI. Now, 24% of participants had had baseline NNRTI resistance with the mutants that weren't significant for Doravirine, as you can see over there. So when we look at the efficacy analysis, and remember we're mainly talking about switches away from a PI, we see that we have non-inferiority. And importantly, none of the participants who received the Doravirine treatment developed viral resistance. So what we're saying is in naive patients, there's a small risk of failure, about 1%. However, for those patients who were undetectable, there were no resistance mutations, and that's really reassuring. How about adverse events? How tolerable was it? What we see here is it was really tolerable, and the predominant side effect that people experienced was headache, but there were very, very few discontinuations. What about change from baseline in terms of fasting lipids? Well, here we see favorable lipids, as we have done in the naive studies, predominantly in patients switching away from PI. What about weight data? So weight is a really topical issue, and it's something that is really affecting outcomes with integrase inhibitors. And we've seen some quite shocking data this year in terms of weight gain in studies like the ADVANCE trial, and particularly, but in fact, all of the studies on the bictegravir program, on dolutegravir programs. So what we looked at in this analysis, and this is something I actually presented last year, was the change in body weight from baseline in the first-line treatment studies. So what we did in this analysis is we combined all the patients in the phase 3 studies I've just talked about, and also the phase 2b study who received Doravirine, and we compared it in terms of the weight gain, mean weight change on the left and median weight change on the right over 1 year and over 2 years. And what you see is that these were very, very similar in terms of the findings, in terms of weight gain. And in fact, Doravirine was very, very similar at week 96 to efavirenz and to darunavir. So this is good news. And if we look at the summary of the weight change category, so the people that had less than 5% weight gain, or 5 to 10% in yellow, or red, greater than 10%, you can see that these were remarkably similar across the different arms. So this is very, very reassuring, because the efavirenz is generally used as the comparator of choice to evaluate weight gain, particularly in the ADVANCE study. So seeing that Doravirine performs similar to efavirenz is very reassuring. What about those who had more than 10% weight gain? Well, once again, here you see that this is incredibly similar between all three of the groups. I would point out once again that these were predominantly men, and we do worry more about weight gain in Black women, and very few of the people were Black women in the study, but nonetheless, this is very reassuring. So here, I'm going to show you the data from the DRIVE-SHIFT study when you switched away from Doravirine. And so we switched to Doravirine away from the baseline regimen. So here the data are for between now and from the baseline to week 144. And we're going to look at it in terms of immediate switch group and then the delayed switch group. And we're going to look at it by regimen that they switched away from. So interestingly, what you can see and what is kind of striking is the integrase inhibitor class. So those patients that switched away from integrase inhibitors is at the bottom. And if you look at the weight gain, you see that there was the smallest amount of weight gain for the patients who switched to Doravirine away from an integrase inhibitor. Now, this is quite an interesting finding, because one of the key questions that everyone is asking me every time I give a talk is, what do you do if you've got a patient who's gained a lot of weight on an integrase inhibitor? Can you switch them? And if you switch them, what would you switch them to? So we're not seeing a weight loss here, but what we are seeing is certainly a much slower rate of weight gain for those people switched away from an integrase inhibitor. So this is certainly something that's interesting and worth investigating in the real world. So the conclusions that I would draw from this study is that amongst virologically suppressed adults who switched to Doravirine 3TC and TDF, the weight gain over 144 weeks was modest. The mean change was less than 1 kilogram at 6 months and 12 months after switch, and this is very similar to the uninfected population. Over 2 years, more than 2 years on Doravirine 3TC TDF, there was a mean change of weight of about 1.4 kilograms. Interestingly, 70% of the participants experienced less than 5% weight gain, and that's consistent with the naive data. And less than 10 had significant weight gain, and again, that's consistent with the naive data. And there was no difference in weight gain by ethnicity, gender, or sex, or race. And interesting, as I've said, the trend towards less weight gain after switch to integrase inhibitors versus the other classes. So I do think this is quite an interesting study. And I think we're going to potentially hear more about this in the future. What I want to do now is I want to show you what I've called a miscellany of Doravirine. So some other issues. Now, one of the selling points of Doravirine is that it's unlikely to be a victim of PK interactions. So what this means is its levels are unlikely to be very much changed by concomitant medications. And you'll see that there are a few notable exceptions that in terms of drugs you would actually prescribe it with. And you can see that it is affected negatively by rifampicin, and it is affected also by rifabutin. So these are problematic combinations. You can see that for rifabutin, it's less affected than rifampicin. So it is not the greatest of drugs for TB. And in terms of a perpetrator, in terms of drug side effects that it causes, not very many. So you can see that other than dolutegravir, it doesn't really affect PK adversely. So I'm going to move from here to talk about the use of Doravirine with islatravir. So at the moment, there are phase 3 trials looking at Doravirine together with islatravir. So islatravir is a novel NRTTI, so a nucleoside reverse transcriptase translocation inhibitor. And it is a very potent drug. It's potent at picomolar concentrations, and it's being developed in a number of ways. It's being developed as an oral tablet together with Doravirine, which is what I'm going to talk about. But beyond this, it's also being looked at as a once weekly agent and potentially as an implant. So it's a very versatile compound. But where we've got to in terms of using this drug at the moment is there's a phase 2b dose ranging study of Doravirine together with islatravir of about 120 patients, 90 on Doravirine at the different doses. So what we see here is the primary outcomes in terms of efficacy through week 48. So what we see in the different doses of islatravir in the blue and in the red is really good outcomes in terms of the snapshot with very few failures. So this is reassuring and good news in terms of the drug. If we look at the failures, viral load greater than 50, it's really important to understand these. And this is an analysis that I presented this year at AIDS 2020 virtually. And what we see here is across the 3 different doses, there were 4 people who were bounded with viral loads greater than 50 on that group, and there was 1 non-responder in the 2.2.5 milligram dose. There are a couple of early discontinuations who weren't classified as failures, PDVFs, but nonetheless discontinued early due to withdrawals and incarcerations and various factors. But importantly, amongst the PDVFs, in terms of virological failure, none of them had confirmatory viral loads greater than 80, and none met the criteria for resistance testing. And the PK was pretty good for all of these patients. So that's interesting too. If we look at the viral loads by study visit, there you see this in terms of the yellow, all of the patients failed with viral loads less than 200, and the confirmatory values were also less than 200, as you see there. What were the most common adverse events with this particular combination? So like I mentioned in the drive shift study, you can see for the combined islatravir doses in the white column that headache was the commonest, and this was more common than with Doravirine 3TC TDF. You can see diarrhea was similar, and you can see nausea was similar. There were no other really significant adverse events of note. And these adverse events that I'm presenting to you here were adverse events with an incidence of greater than 10% in any group. So one of the important parameters always is the metabolic parameters. And what you see here for the different groups versus TDF group is that the cholesterol ratios and were all good, and the glucose was good. Now we must remember that the advantage is actually to the TDF containing arm, because we know that TDF has this magical weight loss inducing and lipid lowering property. So it's actually reassuring to see that without the TDF on the 2DR arm, the outcomes were actually excellent too in terms of the metabolic parameters. Now we come to weight. And as I've said to you, this is the hot topic of 2020. It's the hot topic of 2019. So what we want to understand here is what was firstly, what was the weight percentage change from baseline, and how many people had more than a 5% increase. So I'll remind you that the Doraviron 3TC TDF comparator is in gray. So what you see is numerically, it is looking slightly higher for the three groups with islatravir. But if you look on the table on the right, and I do think this is a very interesting finding, the islatravir combined arms is the second to lowermost row on the right-hand table. And if you look at week 48, you see that 37.8% of people had more than a 5% increase. And if you look below at the Doraviron 3TC TDF, you see that it was 22%. Now, this was something that was not focused on at the AIDS 2020 meeting, and this is because the numbers are small and we're only looking at a phase 2 study. However, I would conclude that actually I would notice that there was a difference between the NRTI TDF containing 3-drug regimen and the novel combination of Doraviron and islatravir. So with that, I'm going to conclude here. We are on an online webinar, but I'd like to conclude and say thank you very much for listening, and I hope that this has been informative for you. Thank you so much.
Thank you, Chloe. Now, new reverse transcriptase inhibitors, including the novel nucleoside reverse transcriptase translocation inhibitors, are emerging options for both treatment and prevention of HIV infection. During his talk, Jean-Michel Molina will present the most recent clinical data on the potency, safety, and pharmacokinetics of these new antiretrovirals. Jean-Michel Molina is Professor of Infectious Disease at the University of Paris and head of the Infectious Disease Department at the Saint-Louis Hospital in Paris, France. Jean-Michel has been an investigator for many clinical trials of novel compounds and combination therapies. He's a world authority on the prevention of HIV infection with antivirals and has led the ANRS IPA-gay pre-exposure prophylaxis PrEP trial in men who have sex with men, and now a new ANRS PrEP study, the ANRS Prevenir study.
Good morning, good afternoon, good evening. It's a pleasure to be part of this symposium today. And I've been asked to review for you the current data on a new drug for HIV treatment and prevention, islatravir. These are my disclosures. Islatravir is a nucleoside analog which inhibits the HIV reverse transcriptase with a novel mechanism of action. And that's why it is called a reverse transcriptase translocation inhibitor, or NRTTI. You can see here the chemical structure of islatravir, formerly known as EFDA or MK8591, which is an adenosine analog with an hydroxyl group here, which is found in natural nucleotides and has a very high binding affinity for the HIV RT. There is also an ethinyl group here with the ability to block translocation and cause immediate chain termination. In addition, there is a fluoro group which can inhibit islatravir metabolism and contribute to its long half-life. In vitro, islatravir has a very low IC50 in the nanomolar range with concentration of islatravir triphosphate, the active compound in PBMC. In the macaque model, the IC50 of islatravir is also quite low in the picomolar range. Interestingly, islatravir has no or very weak inhibition of human DNA polymerase, alpha, beta, and gamma, which is relevant for a low potential for mitochondrial toxicity. The half-life of islatravir triphosphate in healthy adults in PBMC is on average 120 hours, which is quite longer than the half-life that we know for tenofovir triphosphate. This slide shows you the in vitro activity of islatravir on different HIV subtypes. And you can see that the phenotypic susceptibility as compared to laboratory HIV strain remains below 1, suggesting that the activity is retained in all these HIV-1 subtypes, as we know for the other NITIs, the Davidine, tenofovir, and lamivudine. Interestingly, islatravir has also in vitro activity against HIV-2, but no activity against HBV, and this is something we may need to recall when using this drug in the clinic. This slide shows you the in vitro activity of islatravir using the monogram phenosens assay on different HIV strains with different types of NITI resistant mutations. And you can see that as compared to the wild type strain, when you look at strains with the M184V mutation, you have a 5-fold increase in the phenotypic assay with an increase in the IC50, which remain quite low at 1 nanomolar. On the other hand, with the Q151 mutation, the fold change is below 1, which can be translated as a hypersensitivity or susceptibility of the strain to islatravir, which is quite interesting. However, the 69 insertion is associated with a 10-fold change increase in the monogram assay, with still IC50 at 2 nanomolar. With the more frequent mutation, P65R, again, as you can see, the fold change in phenotypic susceptibility is below 1, which again is in favor of an hypersusceptibility of this strain to islatravir. However, 3 times combined increase the fold change 3-fold, and 3 times plus the M184V mutation, you also increase the phenotypic susceptibility by 11-fold, with an IC50 remaining in the range of 2.2 nanomolar. Another way to look at this data is to plot the IC50 in the y-axis, and on the x-axis you have the different strains with different mutation. And you can see that although the islatravir here with the blue spot had the lowest IC50, the IC50 is higher when you have the 69 insertion of a combination of TAMs plus M184V mutation. The first data in HIV-infected patients come from this phase 1 study recently published in the Lancet HIV, where 30 treatment-naive people received a single dose of islatravir ranging from 0.5 to 30 milligram. And you can see that there was a decline by 7 days of HIV RNA as compared to baseline by at least 1 log, which is quite nice, with no emergence of viral resistance. And in terms of safety, the only drug-related adverse events were headaches in 6 individuals and diarrhea in 2. There was no SAEs. This phase 1 study was an opportunity to look at PK in those patients. So when you look at plasma PK, you can see that the AUC increases with a nice dose proportional increase. The Tmax is reached after 30 minutes to an hour. And when you look at islatravir triphosphate levels in PBMC, you can see again that the PK increase is dose proportional. And after 7 days, you can see that the islatravir triphosphate concentration remains above 0.1 picomole per 10 to the 6 PBMCs. Interestingly, the half-life is in the range of 120 hours, which is an interesting attribute of this drug. Another way to look at this data is to correlate the islatravir triphosphate concentration here on the x-axis with the viral load decline, and you see a nice correlation with greater decline with increased islatravir triphosphate concentration. And these data were used to try to define the threshold of islatravir triphosphate concentration in PBMCs. And you can see that this threshold of 0.05 picomole per 10 to the 6th cells was defined as a threshold associated with the decline in viral load of at least 0.5 log here, the black dots, but in some individuals up to 1.5 logs. Interestingly, islatravir triphosphate concentration in rectal and vaginal tissues were similar to those seen in PBMC, which is interesting when we will discuss later on the use of islatravir for prophylaxis. If we now look at another study conducted with the use of islatravir given weekly, and you look at PK concentration, again, of islatravir triphosphate in PBMC, you can see that even at the lowest dose used, 10 milligram weekly, after a week, the trough levels were above the threshold here of 0.05 picomole. And when the patients received 3 doses of islatravir after week 3, you could see that a week after this third administration, concentration remained way above this threshold. But that was true also a week later, which is important regarding forgiveness when we will use this drug on a weekly regimen. And that's the reason why islatravir right now is considered for development for both treatment given once daily in combination with doravirine or once weekly in combination with another NNATI. It is also being developed as a drug for prevention, for PrEP, given once monthly and potentially even once yearly if we can use this drug in an implant. Let's look first at the data for the treatment of HIV infection. And these are data when islatravir is used in combination with doravirine given daily. So this was a randomized placebo-controlled study, which results have been presented in Mexico last year. So these treatment-naive patients with CD4 cell count above 200, no ART resistance mutations, no active hepatitis C or B, and these individuals were randomized to receive for the first 24 weeks islatravir in combination with doravirine and 3TC at 3 different doses of islatravir, 0.25, 0.75, and 2.25 milligram QD. Or in the control arm, patients received doravirine, 3TC, and tenofovir. In the first 3 arms, if the viral load was below 50 copies at week 20, the patients were switched to the dual regimen of islatravir and doravirine up to week 48. After which the dose of islatravir was selected for the maintenance part. Interestingly, the stratification for randomization was made on HIV RNA level and below or above 100,000 copies per ml. In terms of baseline characteristics, you can see that almost all patients were male, pretty young, 28 years of age, mostly white, with a CD4 cell count above 400 and a median plasma HIV RNA of 4.6 log. But you would appreciate that when you look at the patients with the highest viral load, above 100,000 copies per ml, the proportion in the islatravir arm was a little bit higher, 20 to 29%, as compared to only 16% with doravirine, 3TC, and tenofovir. Let's look now at the mean log change from baseline HIV RNA over time. And at week 48, you could see that in all groups, there was a nice decline by, on average, 3 logs of this HIV RNA. The primary endpoint of this study was at week 48, the proportion of patients who achieved less than 50 copies of plasma HIV RNA. And you can see that overall response rates were high in all groups. When you look at the proportion of patients with a viral load above 50 copies at week 48, it was, again, similar in all groups, except maybe in the high-dose islatravir group, where 4 patients out of 31 had a viral load above 50. But when we look at the patients who had the protocol-defined virologic failure at week 48, you can see that only 1 to 2 individuals per group reached its definition of virologic failure, which was quite conservative, since it was based on a confirmed HIV RNA above 50 copies. So if your patient had a rebound of HIV RNA above 50 copies, you had to discontinue study drug and to switch to triple regimen. What is interesting to note is that in all cases of PDVF, the viral load remained below 80 copies. So no one reached the 200 copies threshold that would allow for genotypic resistant testing. And in addition, when the patient switched to the triple regimen, 5 out of the 6 patients had their viral load back to less than 50 copies at the time of the switch. Also, the PK of islatravir in those people who had PDVF was similar to the other participants. So it's not a PK issue here that was responsible for these PDVF. The CD4 cell count changes from baseline was, as expected, quite significant in all arms, although here at week 48, a little bit lower with the high dose of islatravir. And in terms of safety, it's interesting to see that when you look at drug-related adverse events, the proportion was actually higher in the control arm as compared to the combined islatravir arm here, 19.4% versus 7.8%. And that overall only 2 individuals discontinued islatravir doravirine because of a drug-related adverse event. 1 individual had GI symptoms at day 200, and another one had an HPV reactivation at day 200. If we look at the most common adverse events reported during these first 48 weeks, you can see that headaches were reported more frequently with islatravir as compared to the control arm, but diarrhea were more frequent with the control arm of doravirine 3TC tenofovir as compared with islatravir doravirine, and nausea were reported in 9% in all groups overall. Lab abnormalities were quite infrequent and again similar across all groups, with 2 individuals here having a grade 3 increase in triglycerides, and a couple of people with increase in creatine kinase, which actually resolved spontaneously, and most of these individuals had physical exertion that may have explained this increase in creatine kinase. When we look at other metabolic parameters, so glucose level here on the left-hand side, very minimal changes over time and no significant differences between the groups. Interestingly enough, in all groups, there was a decrease in the total cholesterol to HDL cholesterol ratio, which is quite a good thing. Let's look now at weight changes from baseline in these individuals. What you can see here is the percent change from baseline in body weight. And you can see on these graphs that the body weight increases over time, mostly during the first 24 weeks, but also at week 48. And in this table, you have here the proportion of patients who had more than 5% increase from body weight since baseline. And you can see that this proportion was 22.6% with doravirine 3TC tenofovir and 37.8% with the islatravir arms combined. So this is something we may need to continue to monitor in future studies with islatravir doravirine. So in conclusion, this phase 2 study shows you that patients who initiated treatment with islatravir doravirine and 3TC and switched to islatravir doravirine once the viral load was below 50 maintained this high efficacy at week 48. The safety was also pretty good, with only 2 participants discontinuing the study drug because of adverse events. And so these results were good enough to continue the investigation of these new drug in phase 3 trial. And you have here a list of phase 3 trials which have started in heavily treatment experienced, in virologic suppressed patients, or in treatment naive patients, both adults and adolescents. And in all trials, the combination tested was doravirine 100 milligram and islatravir 0.75 milligrams per day. But as I told you at the beginning of my talk, islatravir has also the potential to be used for prevention. And this is a study done by Marty Markowitz's group, recently published, where they used their macaque model with Shiv rectal challenges every week. And they gave macaques islatravir a week before each challenge. And when they used dose of islatravir at 3.9 milligram per kilo in these macaques, as you can see here, there was full prevention of Shiv infection in all these animals. They decreased the dose of islatravir, and they showed that at doses as low as 0.1 milligram per kilo in these animals, they were able to prevent Shiv infection in this rectal challenge model. And this is, of course, relevant to the use of islatravir in humans. Another interesting way of using islatravir for prevention is the use of islatravir implants. And Merck is using the technology they know for Nexplanon, their contraceptive implants, and they were able to insert islatravir in this implant. And you have here an X-ray computed tomography picture of the islatravir implant. And you know that the Nexplanon implant is 4 centimeters in length and is an interesting way of prevention for the future. You have here a simulated PK profile of islatravir when used in an implant. But more recently at IAS, PK data in individuals who had this implant inserted were presented. And when the implant contained 62 milligrams of islatravir, you can see that over time, up to 12 weeks, the islatravir triphosphate concentration in PBMC was above the target concentration of 0.05 picomole per 10 to the 6th cells. And when the implant was removed, the concentration was still above this threshold for the next 3 weeks. And at Merck, they simulated actually the PK of islatravir using this implant if the implant was not removed after 12 weeks. And they showed in this graph that in their model, actually, concentration of islatravir triphosphate above the target concentration was probably maintained for nearly a year. And of course, that's quite exciting when you think of being able to prevent HIV infection with an implant for a year. More provocative is the use of islatravir for PEP. And in the same macaque model, Marty Markowitz and colleague presented at CROI earlier this year, the use of islatravir given 24 hours after an HIV Shiv IV challenge in the macaques. And you can see here that using a single dose of islatravir 24 hours after the IV Shiv challenge, they were able to protect 4 out of 6 animals. But when they repeated the islatravir dose with 2 doses of islatravir, 3 or 4 doses of islatravir, they were able to protect all animals in this model. So that's also quite interesting to, in the future, maybe look at this strategy for PEP. So in summary, islatravir is a new and a TTI drug with unique features. Preliminary data are quite promising today, even alone or in combination with doravirine for the treatment, but also the prevention of HIV, PrEP, and potentially PEP as well. The safety profile so far looks good. We have multiple delivery options with islatravir. It can be given orally, daily, weekly, even monthly. It can be used also as an implant. So this drug, has a lot of potential, and there are more data to come. So stay tuned to know more about islatravir. I'd like now to finish up by acknowledging my colleagues at the Saint-Louis Hospital and all our funders, and in particular the ENRS in France. And I thank you all for your attention.
Thank you so much, Jean-Michel. Now, toxicity of different drug classes and their clinical implications will be discussed by Laura Waters. Dr. Laura Waters is a GU HIV consultant and HIV lead at the Mortimer Market Centre in London. She's president of the British HIV Association, BEVA, and on the British Association of Sexual Health and HIV, BASH, board, and chair of the BEVA treatment guidelines. She's previous chair of the BASH HIV Special Interest Group and has co-authored several national guidelines. Laura represents BEVA on the HIV Clinical Reference Group, advising the NHS in England on HIV treatment and care. She's published widely, writes a regular column for the Boys magazine, and is a Terence Higgins Trust trustee. Thank you, Laura.
Hi everybody, I'm Laura Waters from the Mortimer Market Centre in London, and I'm talking about toxicity and clinical implications of different drug classes. These are my disclosures. Now, when I saw the title of this talk for 15 minutes, I did panic somewhat. What do I choose? There are so many classes, there's so many toxicities we could discuss. But then I remembered it's a reverse transcriptase symposium, so I'll be focusing primarily on the class toxicities associated with the nucleoside and non-nucleoside reverse transcriptase inhibitors. I'll also touch on the other major drug classes in current use, protease inhibitors and integrase inhibitors. So starting with NRTI, and I think this class exemplifies more than any other the evolution from ugly duckling to swan. If we look at the pre-heart NRTIs, this is the NRTIs developed before the mid-1990s, we had the evolution from zidovudine in 1987 through to didanosine and zalcitabine, stavudine, and then finally lamivudine in 1995. Now, the issue with this drug class was primarily related to toxicity secondary to mitochondrial dysfunction. And this was driven by impaired mitochondrial DNA production secondary to the inhibition of polymerase gamma by NRTIs. Polymerase gamma is the human polymerase most affected by NRTIs, and mitochondrial dysfunction can result. And this is where it gets quite interesting from a pharmacological perspective, because if you look at the different chiral forms of the same drug, taking lamivudine as an example, the negative chiral form of lamivudine has much less affinity for polymerase gamma than the positive, yet the same impact on reverse transcriptase. So this is the version that was developed and is the 3TC we know and mainly love. Also, it depends on how well the NRTI is excised from that polymerase. So after binding, lamivudine is excised much more efficiently than zidovudine, for example, which once bound that polymerase pretty much stays stuck there. So it's the affinity for polymerase and the rate of removal that are important. The other key thing are the tissues affected. So if we think back to some of those classic signature NRTI toxicities, such as lipoatrophy associated with zidovudine and stavudine, that was due to mitochondrial toxicity of fat cells. And some of those classic toxicities varied according to propensity for particular cell types. What about the post-heart NRTIs? And here we have abacavir, tenofovir DF and emtricitabine, and then a large gap until tenofovir AF, which was licensed in 2016. These are the European licensing years. And again, from a pharmacological perspective, this is interesting. So emtricitabine is modified 3TC with the addition of a 5-fluorinated cytosine. And what that means is it has less affinity for polymerase gamma, which is already low, and slightly more reverse transcriptase affinity, which may account, if we're splitting hairs, for a slightly higher genetic barrier in clinical studies. Moving on from mitochondria though, abacavir was a very interesting drug, of course used less today, and it actually has a low propensity for mitochondrial toxicity. So here new mechanisms emerge. The classic toxicity of abacavir hypersensitivity, which is a delayed type reaction, occurs in people who carry the HLA-B5701 allele. There have been no proven, and that means patch test proven, abacavir hypersensitivity reactions in people who are negative for this allele. And this remains one of the best examples of successful use of pharmacogenetics in clinical practice. Cardiovascular disease is the other, albeit debated, toxicity associated with abacavir, although I think most agree there is a signal. And the studied mechanisms include endothelial dysfunction and vascular inflammation, and actually structurally abacavir is very similar to some of the endogenous purines which are involved in signaling and can be prothrombotic and pro-inflammatory. The other well-studied mechanism is platelet aggregation, and by more than one mechanism, abacavir makes platelets more sticky. Tenofovir DF, I won't go into great detail here. I'm sure you'll be familiar with the classic toxicity profile for TDF, But renal toxicity, which can be a chronic kidney disease or a proximal tubulopathy type, the mechanism isn't entirely understood. It's possibly due to mitochondrial toxicity, and although TDF has a low affinity for polymerase gamma, the renal proximal tubule is particularly sensitive to mitochondrial toxicity. But we do know the renal toxicity correlates with plasma exposure because we see more with boosters, which increase plasma and intracellular tenofovir exposure, and also there are some pharmacogenomic associations. Bone mineral density loss is the other classic adverse event. The mechanism's not clear. It may be mitochondrial and may be related to low-grade renal phosphate loss. I think one of the key things to point out, though, is most of the evidence for TDF and bone loss is based on DEXA, and DEXA cannot distinguish osteomalacia from osteoporosis. And that led to a conundrum for many years. You had the renal and bone concerns for TDF and the cardiovascular concerns for abacavir. But then, of course, along came tenofovir AF, the angel NRTI, that would be associated with far less toxicity. And when it comes to renal and bone markers, that is indeed the case. But is TAF truly an angel? And I think there are still some issues potentially related to very high intracellular concentrations in some cell types in animal studies, including pulmonary cells. There have been case reports, albeit very few, of nephrotoxicity, because ultimately tenofovir is still the active drug. TAF has a suboptimal lipid profile compared to TDF. And in the TANGO study, which was a switch study for people suppressed on TAF-based 3-drug regimens, randomized to continue or to switch to dolutegravir lamivudine dual therapy, there were lipid improvements which were most marked if they were on a boosted regimen at baseline. So removing TAF and a booster and switching to dolutegravir lamivudine improved lipids. The HOMA-IR, a mechanism of insulin sensitivity, improved significantly if people were on a booster, and although it wasn't significant, there was still a trend if they were on an unboosted TAF-based regimen. So possible differences emerging here between a TAF FTC and a lamivudine backbone. Weight, of course, has been the big story. I won't go through all the data, but this was presented in the summer by Paddy Mallon, the US opera cohort. And here people switching only the TDF to TAF component of their suppressive ART saw a sudden upswing in their weight trajectory at the time of TAF switch. We have the advantage of pre-switch weights here, and prior to switch, an annualized weight gain of 0.4 kilos, which went up to 2.64 for the 9 months surrounding switch, and then plateaued at an annualized weight gain of 0.3 kilos per year. Now, these lipid changes and weight changes when switching from TDF to TAF may be associated with an increase in estimated cardiovascular risk. This was illustrated in this retrospective US cohort of 110 people. And the key message is BMI, lipids, and the atherosclerotic cardiovascular disease risk score all increased on switch from TDF to TAF. But it's important because if you use a cardiovascular risk calculator based only on lipid ratio, you may miss changes in LDL that would affect risk using other calculators like ASCVD. Now, this year, we actually saw some clinical endpoints, and this is a Netherlands retrospective cohort looking at emergent cardiac events. People on TAF had significantly more new cardiac events on people on TDF or people on no tenofovir at all. The difference between TDF and no tenofovir was not statistically significant, but the difference for TAF compared to both of those groups was. Now, they controlled for various factors such as gender, smoking, and previous cardiac history, but they were not able to adjust for renal impairment. And clearly, that's a risk factor for cardiovascular disease and a driver of being on TAF. So more work is warranted, of course, but this is a signal worthy of some caution at the moment, I think. So the final question for this class, what about our next NRTI, which of course, as you know, is an NRTTI, is latravir. Of course, we don't know much yet. It's not been studied widely, but it's important to point out here, this study showed it has a very low propensity for interactions with polymerase gamma, so it's going to look pretty clean from that perspective. What are the clinical implications finally? Well, most older NRTI are no longer in use. Lamivudine is considered pretty inert, such that we're very happy to include it where it may offer some activity, even in the presence of resistance. B5701 testing is now standard prior to abacavir use, and abacavir is not recommended for people with high cardiovascular risk. TDF isn't recommended in people with renal or bone disease or at high risk of either of those, but I think to a degree it may be unfairly demonized, except in England where we love using TDF, because certainly if you use it in the right people with unboosted third agents, it appears to be fairly safe. TAF is considered a safe option, but the question, is it really? And I think we need to understand more about the impact of lipids, of weight, and this possible signal related to cardiac events. Moving on to NNRTI, the first generation NNRTIs were licensed in the late 1990s, and nevirapine was actually a very good drug once you were stable on it. And after 3 months, it has a very good toxicity profile, but its use is limited by severe hypersensitivity, with up to 1% of people developing a severe rash, and hepatic hypersensitivity, which can be fatal. It's an immune-mediated hypersensitivity related to CD4 with a higher risk at higher CD4 counts, and some HLA associations, though the studies proving this tend to be small and the associations are weak. Efaviren's also associated with rash and hepatotoxicity, though to a lesser degree than nevirapine, and most people with efaviren's rash could be treated through it. But the hallmark toxicity, of course, is neuropsychiatric. This is likely a direct neuronal toxicity effect, and there have been a number of mechanisms postulated, including calcium channel pathways and cannabinoid pathways. Immune-mediated hepatic injury is uncommon, but hyperlipidemia is common. It's important, however, to note that in the DAD studies, which first showed us about the abacavir and cardiovascular disease risk signal, these NNRTIs were not associated with elevated cardiovascular risk. So moving on to the second generation NNRTIs, etravirine, licensed in 2008, also associated with rash and transaminitis, though to a less severe degree, certainly than nevirapine, and a better lipid profile than efaviren's. And though there was some improvement, this was still consistent with a rash and hepatitis NNRTI class toxicity. But then rilpivirine in 2011 with much lower rates of rash, 2% compared to 13% on efaviren's in the registrational studies, less transaminitis in those same trials, relatively lipid neutral, and really no signature toxicity. So this second generation NNRTI really shifting along and moving away from those NNRTI class effects. And then finally, of course, we have our third generation NNRTI, doravirine. Now, these are the structures. I'm no pharmacology expert really, but you can see the structure of doravirine is very different to the second generation and to efavirenz shown here. That to me means it's likely to behave differently. And certainly if we look at rash, it's less common. And importantly, in the driver head study, the first line comparison with efavirenz, there were no rash related discontinuations on doravirine compared to almost 3% in the efavirenz arm. Liver toxicity from the liver tox database, there are no reports of clinically apparent hepatotoxicity. Transaminitis is rare, although more common, as you would expect, in hepatitis B or C co-infected patients. And finally, from a lipid regard, and here again the head-to-head comparison with efavirenz first line, you can see a really optimal lipid profile with a reduction in LDL, total cholesterol, and triglycerides. So clinical implications, NNRTI class toxicities were primarily associated with the first generation and etravirine. One caveat though is the etravirine registrational studies were in highly treatment experienced people and often combined with many other drugs, which can of course cloud the interpretation. Rilpivirine and doravirine have good safety profiles, but there is a lack of long-term cohort data for our newer NNRTI, so vigilance and reporting are still key. Protease inhibitors, we have one slide, a message. The old ones were horrible, the modern ones are better, but issues include an association with chronic kidney disease, cardiovascular disease, gastrointestinal toxicity, and although the new ones are better than the old ones, they are still worse compared to other classes. And of course, the indirect toxicity associated with boosters and drug-drug interactions. The clinical implications are that PIs still have a role, but really they're an exception rather than first choice. And of course, we should endeavour to switch to non-boosted options where there are reasonable alternatives. Finally, integrase inhibitors, and you can see the timeline here for raltegravir through to bictegravir over an approximately 10-year period. Now, one of the initial toxicities associated primarily with raltegravir was myotoxicity, although that's thankfully uncommon. The other issue has been with CNS toxicity, and here dolutegravir has been particularly implicated, but in the cohorts that was particularly associated with abacavir use, which we'll touch on shortly. The other issue, of course, has been the pregnancy safety signal for dolutegravir, though reassuringly that is no longer a significant difference, although numerically there remains a small increased risk of neural tube defects for women who are exposed to dolutegravir at conception. And finally, the weight issue, which I shall touch on. Now, there are some very key considerations before I move on. The first thing is the importance of placebo and comparator. So if you look at the STRIBUILD first-line studies and the prevalence of abnormal dreams at week 48, in the Gilead 102 study compared to efavirenz blinded study, it was 9%. In the 103 study where atazanavir ritonavir was the comparator, it was 0%. So very different rates of abnormal dreams for STRIBUILD depending on the comparator, thus illustrating the impact of placebo. There's also the importance of other drugs in the regimen, and here I use Gilead 1489 and 1490 to illustrate that point. Now in 1490, both bictegravir and dolutegravir are with an FTC TAF backbone. So this is a head-to-head of the two integrases, but in 1489, bictegravir is with FTAF, of course, but dolutegravir is with a bacavir lamivudine. And if you look at the differences in nausea rates and insomnia rates, what you're really seeing there then is an impact of abacavir. Yet if you look at 1489, sometimes that's interpreted as dolutegravir being a less tolerated regimen, but I think that's clearly mainly associated with backbone. The weight signal I won't dwell on, it's been discussed an awful lot over the last couple of years, but here this is a pooled analysis of 8 Gilead first-line studies, bictegravir and dolutegravir associated with more weight gain than elvitegravir, and cohorts also show raltegravir less associated with weight gain than our second generation integrases. So in conclusion, the evolution of antiretroviral therapy has led to marked improvements in toxicity and tolerability profiles. One thing I didn't touch on, but I want to mention is incidence and point prevalence of adverse events over time should be standard. Presenting adverse events over 1 or 2 year periods without looking at how long those adverse events persist is not helpful when counselling patients. So I think we should encourage all trials to report adverse events in this way. As adverse events get less common, post-marketing surveillance, reporting events, and analysing events in cohorts becomes all the more crucial. And as new toxicities emerge, understanding the underlying mechanisms is key so that we can then assess new drugs in the same classes for their potential risk of those same side effects. So I'd like to end by thanking you for your kind attention. There are my contact details should you wish to get in touch, and I hope you enjoy the rest of the meeting.
Oh, Laura, thank you so much for your talk. Now, during my talk, I will emphasize the optimal use of nucleoside reverse transcriptase translocation inhibitors, NRTTIs, and non-nucleoside regimens in routine clinical practice. Here are my disclosures. And now I'd like to sort of set out an agenda. Now, of course, because these aren't licensed yet, this is all theoretical and my own personal view, but I'm going to cover ARTA's start with a 2-drug regimen, ARTA's switch really mainly to avoid or because of side effects. And then I'm going to talk a little bit about drug interactions and tuberculosis and the oral contraceptive pill, a little on pregnancy and HIV too. But really the limits to what I'm going to say about these last 2 subjects, pregnancy and HIV2, is that we have no data on pregnancy, and all we know is that islatravir works for HIV2, but doravirine, which is the other component of this, has no effect. So what's the real advantage of being a 2-drug regimen? Well, there have been increasing concern about other nucleoside toxicities. We had the abacavir story and the tenofovir DF story, which has now been mitigated by the development of TAF, and also about the fact that if you're a 2DR and don't have a boosted agent, it limits drug-drug interactions. Obviously, cost is an issue. Having 2 drugs should cost less than having 3, but that's not perhaps always the case. And we don't know what the cost of any combination of an NRTTI and a non-nuc will be. Fewer drugs obviously may be a good thing, especially in the long term when people are on drugs for 40 years. And you know, we have this issue now with a lot of our cohort being aging, with multimorbidities, with polypharmacy. So perhaps having less drugs is a good thing, not only in terms of being able to take pills, but also because of the drug interactions. Now, there are some limitations. So one is, and especially with the proposed NRTTI and non-nuke combination of islatravir and doravirine, would be about hepatitis B co-infection. You'd have to screen for this first because of the inactivity of that combination against hepatitis B. We don't know about toxicities with new combinations that haven't been discovered yet, and we've seen this with lots of drugs in the past, that it can take several years before new things are thought about. We've seen the weight gain with dolutegravir and TAF and other issues with drugs that have taken a while for us to realize. The other thing is the access to resistance testing. If you're going to do a rapid start with this drug combination, is it safe to give the combination and get the resistance test later, or not to do a resistance test at all? Globally, interactions with TB treatment is very, very important, especially with the rifamycins, and other drug interactions that I'm going to talk about this with the oral contraceptive pill are also important. Pregnancy, where we have no data, and that's very important to have studies whereby we can see whether or not this is safe in pregnancy, and also whether or not it's efficacious. Some drug levels of drugs go down in the 3rd trimester in pregnancy, and there are others that are much more preferred because of their PK profile. We do have an issue though with high viral load and low CD4 with dual 2-drug therapies, and we really need to make sure that if we're going to start these therapies in patients with a very high viral load and a low CD4, that they will be efficacious. And most of these drugs really haven't been studied in patients with more than 500,000 copies in detail. Now, one advantage, of course, of having this combination is that it could be an oral fixed dose combination, which has been used in trials. At the moment, we've got 2 drug single tablet regimens of dolutegravir 3TC and dolutegravir rilpivirine. All these others around the slide here are 3 drug regimens, but you can see that we might be able to have an islatravir doravirine, NRTTI and NNRTI combination, which again would be very useful for patients to be able to take 1 pill once a day. Now, let's talk about starting therapy with this regimen. So there are 2 ways to start. One is immediate start, and the world is moving towards, you've got a diagnosis, and almost on the same day or within a few days, you start antiretroviral therapy. And there's gathering data that increases retention in care and has better outcomes. But what would happen if you don't have a baseline resistance test or even a viral load or CD4 at baseline? How useful would this combination be in those situations? So the concerns would be you have some transmitted resistance to non-nucleosides or even to the islatravir, and the combination wouldn't be effective. Also, if you started with a high viral load and a low CD4, would this work? So in the immediate start scenario, I think we need a lot more data before we can actually say that we would start immediately with a combination like this. Now, what about a planned start? And many patients in the world, it's planned. You're diagnosed, we're going to get your blood test back, and then we're going to put you on the optimal therapy. But the concerns then would be if you had a high viral load and low CD4, even if you had a wild type virus, would this be effective? Well, we don't have much data, but I just wanted to talk about the naive data on islatravir plus doravirine. And this is quite a complicated a story in terms of a trial, but it's very logical. They started with 3 drugs of islatravir and doravirine, but they added 3TC. So it's a 3-drug combination. And as a standard, they had the comparator as doravirine, 3TC, and TDF. And then at week 24, they moved, if patients were undetectable, so this is an induction maintenance more than just a pure naive, they moved to a 2-drug regimen of islatravir doravirine. And there are 3 of these here, all of different doses. So this is then saying which dose should we choose ongoing. And again, they kept a comparator arm. Well, the results were pretty good with, as you can see, various rates of success. Interestingly, this largest dose of islatravir had the less number of percentage developing undetectability through week 48. And in fact, the dose they've gone for is a 0.75. But if we look at this, let's look at some of the patients that had virological failure. Now, the first thing to say is, if you look, here's patient 1, and we can see the baseline CD4 count. And then as we move along here, you can see the viral load. And by week 16, you can see this patient became undetectable, but out at week 48 had a blip at 51 and a confirmed blip at 79. So is this actually a blip, or is this early virological failure? And you can see this along all of these patients. Now, one of the patients actually changed here. This patient changed before, this patient here changed before they reached week 40, where they had the 103, it went up, and before week 48, where it went to 93, and you can see the confirmed was just at 50 copies. So this patient actually switched therapy. These ones with the yellows were on the original randomized therapy after 24 weeks. Now, the interesting thing to note is that all of these viral loads are extremely low. That's the first thing. They're all in what we might think of as a blipping range. And then the second thing to say is that some of these had high viral loads at baseline. You can see 153, 626, and 437. So some of these had quite high viral loads, which is an interesting concept because I just want to come to this in the next slide. And 3 of the 6 patients who then switched to a new regimen still had low-level viremia 42 days after the switch. And again, this comes to the fact that this could be a physiological phenomenon rather than a failure of the drug. And nobody met a criteria to get any resistance testing out of here because they needed to have more than 400 copies. So why did these patients, and some of them, as I've shown you, have high viral load, develop the criteria for virological failure? Well, first of all, did they fail? So they just developed a high viral load, and but interestingly, we would have had to follow them on for a long period of time, and that wouldn't have been ethical, so they had to switch. Was it just a blip? We know that about 4% of all viral loads are blips, and they're often low level. But what you can say is on the confirmation viral load tests, they didn't appear to be blips. They appeared to be true because the confirmation were all higher. Or could this be just virus coming out of the reservoir? And we've seen this in patients who have high viral loads, that they can have this low level viremia, or they can just dip below detectable and come up again for a long period of time. So I think we need to know that. But as I say, if we really want to know whether this combination works in high viral load, we need to have a phase 3 study where those patients are allowed to be included. The CD4 question, low CD4, wasn't answered because you can see down here that the CD4s were actually all over 200. So that's in the naive, although the data's from induction maintenance. What about using a combination like this in switch because of side effects? Now, what are the side effects of the day? And it's weight gain. That's the real important side effect that everybody's been concerning themselves with. Obviously, CNS side effects are always important, and we had those with efavirenz, and then we had insomnia with the dolutegravir and the integrase inhibitors. But this weight gain with integrase inhibitors and tenofovir alafenamide, TAF, has been a concern. We've also always concerned about lipid abnormalities, and the other reason for switching is people with treatment experience who don't have any resistance but want to simplify their therapy. So let's have a look at the adverse events through week 48. In the study that I've just shown you, the induction maintenance, it's not a switch study to show you the adverse events, but it's at least something that you might look out for. And in fact, they were very, very similar in terms of serious adverse event rates a few more with the triple therapy compared with the double therapy arm. And but as you know, they started off with triple, then went to double. But the most important one here was probably headache and diarrhea. But if you then look at the dose that they want to use, the 0.75, the headache compared with the 3-drug regimen and the diarrhea compared with the 3-drug regimen were very similar. And most of these events were mild, transient, and not thought actually to be related to the drug. They did see some elevated creatinine kinase, but no dose-related trends, and most of them were associated with physical exertion and all resolved. And I remember from the early integrase days, we saw some of this, and again, it was probably the same thing, that people cycled to the clinic or ran or did some physical exertion, and then it was seen in the adverse events. So nothing really very different to the doravirine 3TC TDF combination in triple therapy with the double therapy. Now, what about some metabolic changes? Well, you can see here, and if you look at this, this color here, the change in the glucose from baseline, it's very small. This 3.4 is in milligrams per deciliter. And if you think that that's about 0.1, so it's very, very little in millimoles per liter. That's very, very little change at all. And you can see the doravirine 3TC TDF was slightly down, but the confidence intervals were wide. And if you look at the HDL to cholesterol ratio, the total cholesterol to the HDL ratio, you can see there's very little change. This is mean change. It's 0.2, 0.3. It's basically, it goes down a little, but very little indeed, in fact. Now, what about the weight gain? Well, in the way they measured the weight gain here was more than 5% from baseline. And it's a fair way of doing it, because you want to see whether a lot of people gain weight. And you can see from some of the data here that 16% at week 24 for the triple versus the dose they're going to use was more at 40% here. Week 48, 36 versus 22.6. So this could be a signal that there's more weight gain with islatravir, doravirine compared with the triple arm, or it may be some effect of TDF, which of course does not have the same effect as TAF on weight gain from, say, the advanced study. So it's very interesting that it may be an effect of TDF here, keeping the weight down compared with there. Now, the weight gain, as I said, there's current concern with integrase and TF. And what about this? And I want to come into a little bit more detail about the islatravir data, but let's just go to this slide here. Now, these are changes in BMI over time with HIV positive versus HIV negative. And they followed a lot of HIV patients from the Kaiser Permanente cohort over many years. You can see 12 years of follow-up here. And if you look at the HIV negative, they just followed this group up and they gained on average 0.06 kilograms per meter squared per year. So it went from 28.7 to 29.4 in terms of their mean BMI. When you look at the HIV negatives who HIV positives who started on treatment here, you can see they went from 25.8 to 28.4. And one of the theories here is basically that this BMI increase in the HIV positives on treatment was a return to health. Though you can see this graph is still going up, and this one is slightly going up, and it'd be very interesting if they can follow this cohort a little bit longer. So perhaps starting antivirals makes you put weight gain on because you're returning to health. Now, as I said, I wanted to just revisit this, the weight gain on the doravirine islatravir study. And here you can see, here's no change in weight. And here's the sort of scatter at 0 weeks, at 12, at 24, and at 48 of the various different doses of islatravir. And you can see they're really all grouped. There are a few outliers here. And I've already discussed that's the average change. But when you look at this, there really is very, very little difference between them in terms of groupings. Again, it's small numbers of patients. And I think really that We need much bigger studies. And it was interesting that most of this weight gain, and it's true, if you look at this graph and you look at this scatter part here, they're very, very similar, that most of it occurred between 0 and 24. And that's why they think it may reflect a return to health phenomenon. But time will tell. We need to see the trials and we need to see how this pans out. Now, what about using this combination in people with treatment experience and resistance? Now, if you're treatment experienced and you've had a lot of problem with side effects and you're on a complex regimen, you can see that you may be able to switch to this. But what happens if you have treatment experience plus resistance? Well, this is interesting. This is doravirine data that was presented at the AIDS 2020 conference, and they looked at all of these mutations. Now, it's well known that doravirine is effective against K103N, but they also looked at these other mutations that might have some significance with doravirine, these different mutations and even combinations. And actually, if you look here, the fold change was relatively low, all stayed below 5. This Y181C and K103M went just above 3. And here's the interquartile range. And I suppose the discussion here is, if you have an interquartile range that goes above, say, 3 or 4 or reaches 5, how confident are you that the drug's going to work? And then they looked at this various different NNRTIs here, and for example, that if you're susceptible to doravirine, very few people susceptible would also be able to use a travirine. But if you look at doravirine here, if you're on a travirine and susceptible, you can see the cross reaction with doravirine. So this was very interesting in table, in that only 17% of people who doravirine would work would actually be susceptible to ephedrine. So doravirine does have a very good resistance profile, and I think this data is reassuring in terms that if you see these other mutations, then you will have some effect. Now, islatravir resistance is something different. There's been only emergence of resistance to islatravir in selected experiments, and what you can see is the M184, either I or V, and it's causes 3.9 or 5-time fold reduced susceptibility compared with wild type. But what the manufacturers have said is that the concentration you get of islatravir at the clinical dose that we're going to expect should suppress these mutations and should stop them from either occurring, or if you've got them, be able to overcome these. You can see here from another table I've shown it's effective against the K65R, which is very useful. EFDA was the old name for islatravir. So but we have to wait and see. I mean, a study needs to be done in people with the 184I or V, with the K65R, etc., to ensure that this double combination is effective, because what we don't want to do is to generally use a combination in patients who have got background mutations and then find that we're giving effective monotherapy. Now I want to move on to another subject, which is for WHO, for their guidelines, is critically important, is could this combination be used in tuberculosis? Now, you can use these drugs with rifabutin, and so in countries where rifabutin is available and we can treat TB with rifabutin, that's absolutely fine. And doravirine can be used as 100 milligrams BD with rifabutin. There was a poster at AIDS 2020 outlining this, but you can't use doravirine with rifampicin or with rifapentine. Rifapentine is becoming a drug now of the future for prophylaxis. So doravirine can be used with that, and islatravir doesn't interact with cytochrome P450 enzymes, and so it should be able to be used with rifabutin or rifampin. So a combination of doravirine, islatravir, with rifabutin being used in tuberculosis is a potential yes. But most of the world uses rifampin or rifampicin, and therefore it's going to be difficult to use that combination in that situation in most countries in the world. The oral contraception is important, and there's been a study where doravirine, there's no significant interaction, and levonorgestrel and ethinyl estradiol were not effective. So again, for women who are on contraceptives, it appears to be a good combination to be able to give them without concerns that the drug levels of the contraceptives are going to be affected. So we've gone through quite a lot of different ways that we might be able to use this drug, but as I say, we need the answers from clinical trials. So this is the so-called Illuminate Clinical Development Program for the NRTTIs and non-nukes, the doravirine islatravir study. And you can see here the dose, 100 milligram with 0.75. And we're going to look at data, hopefully, that will come out of a double-blind, heavily treatment experienced program of 2 virologically suppressed, one with open label and one with double-blind against Biktarvy, Bictegravir, FTC, and tenofovir alafenamide. So that will be very interesting. I always like to see double-blind studies being performed, and then you can see a big treatment-naive study against Bictegravir, FTC, and TAF, again double-blinded, and then there will be a single-arm study looking at this in either treatment-naive or virologically suppressed adolescents, and again a drug with very few side effects, which has few drug interactions, which is easy to take. Might be of benefit to that particular group. I will just add one other thing, is that they're aiming in this to recruit a large percentages of women into the studies, which is very important because, as you know, the history of HIV in drug development has underrepresented women quite greatly. So this will be important that, this is followed through. So in conclusions, potential route use. Yes, a 2-drug fixed dose combination will be very welcome. As I say, we've got 2 at the moment. This will be a 3rd. The side effect profile looks good, but we need more data. In terms of switching, we need to know more about the weight gain. It appeared that there was, the numbers were a little larger in the dual therapy compared with the triple therapy, but this may have all been a return to health by week 24. Lipids look pretty neutral, as well as does the glucose. We've had no signal about CNS side effects. And in treatment experienced patients with resistance, that is really the study we need to know whether the doravirine polymorphism, in reverse transcriptase, and whether the 184V is going to affect this. We now have seen drug interaction data in tuberculosis, and that rifabutin could be used, not rifampicin. We've seen the data on the oral contraceptive pill. Pregnancy, well, that's going to take a while to come, but we hope that they'll try and gather this data as soon as possible. And the last thing, HIV-2, islatravir is effective, but doravirine isn't. So islatravir as a single agent with other agents like boosted PIs or integrase inhibitors will be useful, but as a doravirine, islatravir would not be. So the future is very interesting for this combination of a new nucleoside analog. And I think in the next 2 to 3 years, we're going to be able to look back at and look at all the data and know exactly where to use this in routine clinical practice. Thank you.